Dear members of White Army, welcome you all for this medicine mentor session. In our undergraduation days or during post-graduation days, one thing which commonly we come across very often, but still we fail to understand the basics of it, is the autoimmune disorders. Yes, we know about n number of autoimmune disorders, but we fail to understand what's really happening there. To teach us the basic pathophysiology of this, we have with us today Dr. Madhuri H S, consultant physician and rheumatologist at Bengaluru, has agreed, and I requested her to take a class on a very important and pertinent topic. She readily agreed, and she's with us today. Welcome to you, madam. And on behalf of all the White Army members, I really feel privileged to have you with us in our White Army platform. We thank you for this and also welcome you for this special session. Over to you, madam.
Okay, thank you, Kishan. Am I visible?
Yeah, clearly.
And even the PPT is visible now, clearly?
Yes, yes.
Okay, so today's topic is about autoimmunity and the related diseases. Though it is an infrequently discussed topic, it is not so rare as we feel. And there is a need for spreading awareness among the doctor community also about this topic. Okay, so this picture shows that autoimmunity is something like a self-destruction. First, moving on to the definition. Okay, so it is defined like this. It's a pathologic state in which an abnormal immune response is directed towards a normal body composition or a constituent. So this is called as self-antigen or an autoantigen. So remember, though it is termed as an antigen, in this scenario of autoimmunity, it is actually a normal tissue itself. And this leads to inflammation, cell injury, and other functional disturbances. So here the problem is with the adaptive or acquired immunity only. We will look at the types of immunity in subsequent slides. First, before going into the pathology and pathogenesis, I want to tell you about what all autoimmune diseases are there to give the gravity and the widespread picture of the autoimmune diseases. So this consists of very common diseases that we come across, like the Hashimoto thyroiditis, which is the commonest cause for hypothyroid among the women, which is so rampant. And now iodine deficiency is no longer a common cause. It is the Hashimoto's thyroiditis. And similarly, there are Graves' disease, type 1 diabetes, Addison's disease, and many of these autoimmune hemolytic anemia, ITP, and some of these neurological conditions like GB, myasthenia gravis, multiple sclerosis. If the intestine is taken, then Crohn's disease and ulcerative colitis are there. So you name any organ, there is some autoimmune disease associated with it. Then there are organ-specific. These were the organ-specific autoimmune diseases. Then there are the non-organ specific or multi-systemic autoimmune diseases also. So here is the most common or most popular disease is the SLE. Then apart from that, there are also other diseases like vasculitis, antiphospholipid antibody syndrome, Sjogren syndrome, and others. Rheumatoid arthritis can be localized and can become generalized if left untreated. So that also can be classified under the systemic autoimmune itself. Now looking at the immune system briefly, it is consisting of two broad categories, that is the innate immunity and the adaptive immunity. Innate immunity consists of physical barriers like the skin, mucous membrane, its secretions. Example, the hydrochloric acid in the stomach is also a kind of immune barrier. Then it also has cells, which are mostly the macrophages, neutrophils, complement cells, dendritic cells, etc. Then in the adaptive immunity, there are two types of cells only. They are the B cells and the T cells. B cells are the ones which produce antibodies. T cells will produce cytokines and their other secretions. To understand autoimmunity further, we have to know the differences between the innate immunity and adaptive immunity. So how to remember? This can be a question, 3-marker or a 5-marker. So you can remember like this. This innate immunity can be compared to a security guard, and the adaptive immunity can be compared to a police personnel. Okay, that is because what is the job of a security guard? Now, if some theft happens at home, he is there always, 24/7, he is there. So he is the first one to give alarm to the house people, to the neighbors, or to the police also. So he is always there. He acts rapidly, and he is not too much trained, but some training he has in terms of defense. So he is going to function in a not very matured way. So in coming to innate immunity further, it is made of physical barrier and chemicals like we discussed, and there is no memory. That is the major difference between innate immunity and the adaptive immunity. Whereas adaptive immunity, like the police personnel, is more trained, or that is what it is there for, defense purpose, on a more advanced scale. But then, like the police always comes late, even the adaptive immunity responds late, only after being called by the innate immunity or the other pathogens themselves. So there is slow activation, but then the effect is much better. The specificity is much better. They know to handle all kinds of thieves like the bacteria, virus, fungi, etc. And also they have memory. That is like the police, how they keep record of all the criminals, and the repeater criminal is easily traced. The adaptive immunity has better processes to combat the infections. So there are some mechanisms preventing autoimmunity. Next few slides are about the pathology and pathogenesis. So even though the defense cells, inside cells, outside cells, everything is there inside our body, there is no inflammation or some attack going on always. Okay, how this is happening, how are the insiders protected, is because of various mechanisms. So I'll give you an analogy for understanding this. First mechanism is sequestration of self-antigens. That means some of these self-antigens have always been intracellular, and they are never exposed to the immune cells at all. So these immune cells are not even aware that some antigens like this exist. So there's no question of reaction among the two. Next, there is generation and maintenance of tolerance. So assume these immune cells are a set of soldiers. They are not just left for their job. They are initially taken for training. So the B soldiers will go to the bone marrow, and the T soldiers will go to the thymus for their training. This training happens in fetal life and infancy. So what are they trained? How to attack the enemy, all those training. But apart from that, how to differentiate the self from the non-self, how to differentiate insiders from the outsiders. That is their important lesson. So this happens at the level of thymus and bone marrow. But there are always some defaulters. So some soldiers don't learn this lesson of how to differentiate between the two. So those soldiers will be removed by the central deletion. That is, at the thymus or bone marrow itself, these autoreactive lymphocytes are destroyed. By chance, if they are let out into the public also, they will not be given any weapon, or they will be made dysfunctional. Okay, this is called peripheral anergy, where the lymphocytes are still alive. These autoreactive lymphocytes are alive, but they are not capable of attacking. That is called peripheral anergy. Another mechanism is receptor replacement. That means they are made dysfunctional to not be able to identify the self-antigen. Another is these regulatory T cells, B cells, etc. So these are like the peacemaking elders in the community. Even though there is a small outbreak between the soldier and the self-antigen, they will come to calm that issue down, and that inflammation will not go out of range. So it will be contained in a very small attack. So despite all these mechanisms in place, still the autoimmunity and the related diseases happen. So that they also have some mechanisms for an occurrence like this. We will see how they occur. So one is the exogenous trigger. Here, the trigger is from an external source. First and the most well-known is the molecular mimicry. If you remember, this rheumatic fever is one classical example for the molecular mimicry. Here, the group A streptococcus has certain molecular components which are very similar to the myosin which is present on the heart cells. So here the body attacks the bacteria and the myosin both because they cannot differentiate which is what, because based on the molecular similarity. Then there is something called super antigen stimulation. What is a super antigen? It's an antigen which has stimulated the immune attack to an extent more than the required amount, or they have caused so much of antibody induction that they don't know now when to stop. Okay, they will go haywire and attack both the outside antigen and the inside tissues before the levels subside. Then there is something called microbiome composition. This microbiome, they are talking about the normal flora in the human body, like the gut bacteria, the skin flora, and the other and the bacteria in other mucosa. So they are of a certain composition for particular individual. If that changes also, it may trigger the autoimmune attack. Then there are endogenous triggers for the autoimmunity, and these consist of altered antigen presentation. Again, this has subcategories. The most easily understandable example is of the sympathetic ophthalmia. Here what happens, you would have heard in ophthal that if one eye is injured because of trauma or surgery or post-infection and all, after a certain time, even the other eye becomes dysfunctional. Even though the normal eye didn't have anything to do with the trauma, this happened. Why is it so? Because the anterior chamber of the eye is a sequestered part. If some trauma caused its leakage into the blood, then there is going to be an antibody response for this. And these antibodies will not know the difference between the injured eye and the uninjured eye. So they will go and attack these sequestered antigens. So other mechanisms are there, like presentation of cryptic epitopes. Cryptic means whatever was hidden. So those were never exposed to the antibodies, and suddenly now they are exposed because of some trigger, mostly unknown. And then there is a reaction. There can be alteration of the self-antigen itself. They never knew that this form of self-antigen also existed, and they are now going to cause an attack. And enhanced function of the antigen presenting cells. These are the mediators between the innate immunity and adaptive immunity. If they start overacting, then also there is going to be an autoimmune disease. There can be increased T cell function and increased B cell function. All these are important mechanisms in multisystemic diseases like SLE. Then defects in the clearance of apoptotic materials. Apoptotic material are the dead cells. If they are not cleared, they are themselves going to behave like antigens. Cytokine imbalance and altered immunoregulation are also the mechanisms. So for all these mechanisms, there can be a backup by some genetic predisposition. This is studied especially among the twins, and 20 to 30% of the cases have some genetic predisposition which causes autoimmunity. Next, among the mechanisms is of how the tissue damage happens. Okay, so there are B cell mediated and T cell mediated. So both the kinds of mechanisms are there. Among the autoantibody mediated, there can be blocking. Example, in myasthenia gravis, the antibodies will go and block the neuromuscular receptors, and that is the mechanism. Whereas in Graves' disease, these antibodies are going to stimulate the thyroid receptor. So they are the stimulating antibodies. Then there can be immune complex deposition. This you would have heard in lupus nephritis or other glomerulonephritis, where the antigen antibody complex will go and get deposited in the subepithelial or subendothelial membranes. Then there is something called opsonization. Example in ITP. Here, the platelets are marked for destruction and then the phagocyte attack happens. There can be complement activation, T cell, then T cell mediated destruction. Here, the cytokines are released, like in ankylosing spondylitis. There is a lot of cytokine increase, which causes joint destruction and cellular cytotoxicity. Now, coming to more important and more interesting aspects of the autoimmune diseases. So these were the mechanisms of how the body is protected and how that protection is lost. So now we will look at the natural course of these diseases. This natural course is about the multi-system autoimmune diseases. For the organ-specific ones, the natural course will be different based on the specific disease. It's going to be usually slowly progressive in that case. Coming to natural course for some disease like SLE, it usually starts in the early adolescence to midlife, like 15 to 20, 40 years. And it is more common in females compared to males. There are very few autoimmune diseases which are more common in males. And then the most important aspect for all the autoimmune diseases is its nature to relapse and remit. Okay. So this is what makes it different from other chronic diseases like diabetes and hypertension, where they are just slowly progressive or stable. Here, relapse means whenever the disease activity is in a peak. Remission means whenever the disease activity in a very low state. But in no place, there can be complete absence of the disease activity. Okay. So relapse and remission is one aspect. Another is the severity is variable. In the same patient, there may be only joint or skin involvement at the age of 20 in a patient, and this can go on to become lupus nephritis after 20 years. Okay, so the same patient also, there's nothing like once disease has been mild, so always disease will be in the same state. There's nothing like that. So disease presentation severity can be variable, and there is going to be multi-system involvement. It can start as a localized autoimmune disease, but then it will take shape in the subsequent years to involve more organs. Let's look at some of the specific tests in autoimmune diseases. For all these patients, we do the general routine tests and whatever else is relevant. But then there are specific tests which will be done only in these conditions. So the most popular or well-known test is the ANA, which is quite indiscriminately used also nowadays. ANA, by the name itself, means anti-nuclear antibody. Here, the antibody is against the nuclear components in the cells. So it can be against the DNA, against histone, nucleolus, etc. So these antibodies bind to components of the nucleus. There are various subsets that are identifiable, like the anti-Rho, anti-histone, anti-dsDNA and all. And there may be many more which are not yet identifiable. So we test ANA by two methods, either of the methods. So it is by indirect immunofluorescence, IIF, or ELISA. Of these, the indirect immunofluorescence is the most reliable. And positive ANA is going to be there in most of these systemic autoimmune diseases. And some of the organ-specific diseases may also have ANA positivity. There is another specific test called the complement level. So in some of the autoimmune diseases where complement activation is a part of the mechanism, the complements are all used up. So they will be low. That's called hypocomplementemia, and that is also an important investigation. So this is to show you the staining patterns of ANA. This first one is the homogeneous staining. So you can see the whole nucleus is stained homogeneously. Second is the speckled. Here there are some speckles and it is not a uniform staining. This is the centromere pattern and this is the nucleolar pattern. In the ANA testing, there are three aspects. One is the pattern of staining. Another is the brightness or intensity of the staining. Third is the dilution in which this intensity is achieved. Okay, all these aspects you have to see when you are interpreting an ANA report. Then other specific tests are for the disease specific antibodies. This is not there in all the autoimmune diseases. This will be there only in the B cell mediated diseases. So B cell is the one producing antibody. So if the mechanism has B cell involvement only, antibodies are going to be there. Most of the times we do anti-CCP for the rheumatoid arthritis. Then anti-thyroid TSH receptor antibody can be done in Graves' disease. Direct Coombs test can be done in autoimmune hemolytic anemia. So these are all antibody mediated autoimmune diseases. We also test for proving that there is some inflammation going on. So what are the markers for inflammation? Not only in autoimmune diseases, even for the infectious inflammation, these are the inflammatory markers. The ESR, CRP, ferritin levels are increased in some of these conditions. The total leukocyte count also will give us a picture. And in cases of chronic inflammation, there will be failure to thrive, anemia, hypoproteinemia, etc. There's another aspect about these autoimmune diseases which are not there for many other diseases. That is, the diagnostic criteria are defined. This is to avoid confusion because there are always overlapping features, or it is not a straightforward disease in most of the cases. So there are some diagnostic criteria, and only if these are fulfilled do we go ahead to do the further tests or label the patient with that diagnosis. Remember, each diagnosis will stick with the patient for rest of their lives, and you cannot be misdiagnosing any patient. So these diagnostic criteria contain clinical features and lab tests. Some diseases contain additional features like the MRI, like in ankylosing spondylitis, MRI report is one of the diagnostic criteria, and genetic testing or the biopsy can also be included. Example is SLIC criteria is there for SLE. There may be 2-3 criteria also for each of the diseases. Now we will look at the fundamental aspects in treatment of the autoimmune diseases. So in organ specific diseases, it is different. For the organ specific, like the hypothyroidism, we don't want to cause generalized immunosuppression, because looking at the risk versus benefit, the risk of immunosuppression is much higher than the benefit. So we want to be more specific. We will give only the minimum intervention which will make the patient's life and health comfortable. So that is, if the organ is not a life-sustaining one, that is, then we will give only enzyme or hormone supplementation. For example, thyroid supplement in hypothyroidism, insulin supplement in type 1 diabetes, B12 supplementation in pernicious anemia. Whereas if that cannot be done, sometimes we can give a locally disease modifying therapy like carbimazole in Graves' disease, and we avoid wheat in gluten enteropathy, PUA therapy for vitiligo. These are the modifying therapies. Then there are some fundamentals for treatment of systemic autoimmune diseases. And even if it is not a multi-system disease, if it is only a major organ involving disease, still immunosuppression will be required. So immunosuppression or the immunosuppressant drugs are the basis for treatment. So they will not just suppress the immunity disorder which is causing the disease, they will cause generalized immunosuppression, most of these. Only the targeted antibodies may cause a particular immunosuppression. So the commonest used immunosuppressants are, you need not memorize all these names. Let it be like, I heard of this name kind of memory is enough. Okay, so glucocorticoids, azathioprine, MMF, methotrexate, cyclophosphamide, cyclosporin. So these are all the commonly used immunosuppressant drugs, and they are quite old also, and lot of evidence is there in their practice. There are newer immunosuppressants which are the biological agents. These are the rituximab, TNF alpha inhibitors, JAK inhibitors, etc. Apart from these, even IVIG has a role in some of the conditions. Though it cannot be called as an immunosuppressant, it is used in some of these serious cases. Then there is something called, there are some treatment principles in autoimmune disease treatment. So here the treatment will go on for months to years, and some cases it will go on for the entire lifetime. This is what makes some of the people turn towards Ayurvedic medicines or any other alternate forms. But even there, it will be required for many months to years. And then we use something called an induction phase and a maintenance phase. This you would have heard in the TB treatment also. Induction phase has more number of drugs or the more doses, more dosage of each drug. That is to bring down the active disease quite rapidly to a stable phase. And then the maintenance phase is to manage the disease in that low activity state. Immunosuppressants will bring down the abnormal activity of the immune system to states of remission. So causing remission is the goal of treatment in all our autoimmune diseases. Cure cannot be achieved, but permanent remission is achievable sometimes, but if at least reasonable amount of remission period is achievable in most of the times. However, remission period is variable. What is the most common cause for disease flare? It is the non-compliance to drugs. Especially in our country, peri-marriage non-compliance is very common. Unplanned pregnancy and non-compliance because of the pregnancy is quite common. So all these will make the disease flare. Other issues may be some infections, pregnancy, or unknown drug interactions, etc. And many times there is no specific cause, idiopathic cause. So all these are reasons for flare. So our treatment goal is to avoid flares, keep the patient in remission with least side effects with the medicines. So how is the prognosis? Till 20 years back, it was a different story. The prognosis was usually bad, or the treatment side effect was so much that it was as hampering as the disease itself. But now there has been significant advance in the diagnostic armamentarium and the treatment both. So prognosis is quite good, especially for localized diseases like rheumatoid arthritis or the ankylosing spondylitis. Treatment has been excellent nowadays. Okay, so treatment, the prognosis depends on many aspects. The first is severity of the disease. Though the disease is same, the severity is not uniform in many patients. For example, some lucky patients in the rheumatoid arthritis itself will be very slowly progressive for first 2 to 3 years, whereas some others may go on to become deformed in a span of 3 to 4 years itself. So the prognosis is dependent on the disease severity. Then the time to diagnosis and appropriate treatment. This is one aspect which we can change. The severity is not in our hands. So the time to diagnosis should be as minimal. The patients should be little aware so that they reach the right doctor, or at least the referral system should be good, that the patient lands up in the correct treating center. Then the treatment tolerability and compliance is the next aspect of importance. And there are other patient factors also, like if the patient is in the reproductive age group, some treatment cannot be given. If they are in, they are having comorbidities like diabetes, then some treatment may not be given, or they may not tolerate it well. Like for example, the nephrotoxic drugs are not well tolerated by the diabetic patients. So there are all these aspects along with the social aspects, very important, but underrated aspect is the social aspect. If the patient family is an educated one, financially well-to-do, then the prognosis is much better than the patients who do not have this privilege. Okay, so good prognosis is achievable by timely referral to an expert doctor or a rheumatologist. Now let's look at the adverse effect with these immunosuppressant drugs. So this is one botheration for the prescribing doctors also and for the patients also, that all these drugs have a lot of side effects. It's partially true also, but the side effects can be tailored if it is used appropriately. Anyhow, the risk versus benefit, the risk of not taking treatment is much more, and the benefit of treatment despite having side effects is much better. So what are the common side effects, especially with the steroid? You all know that the Cushing's disease is a very common side effect. So what is the commonest cause for Cushing's in our country? It is the iatrogenic Cushing's. That means because of steroid abuse from outside. Whether it is given appropriately or inappropriately is another question. But then iatrogenic Cushing's is the most common cause for Cushing's. So what can you do about that is avoid flares of these diseases as much as possible, because with each flare there is going to be a high dose of steroid that has to be given. Okay, so using steroid sparing agents at the right time is also important. Many times with some dose of Vizolone or methylpred, the patient improves and no second agent is added at all. So they will go on to develop a flare again in few days, and again pulse methylpred has to be given. So this should not happen. Even though the response is good, some backup second line immunosuppressant is required for the steroid usage to be kept at a minimum. Then the patients have to stick to the regimen and come for follow-up often. Otherwise, some 20 mg Vizolone is prescribed for 1 month. They will not come back and take that same dose for many more months. That is not good. And this has happened quite a number of times. Supportive medicines like the antacid, calcium, etc., they are also very important, because taking calcium or vitamin D or bisphosphonates can prevent a fall and fracture, which otherwise itself is a cause for death in some of these patients. And avoidance of infections whenever it is possible, because that susceptibility to infection itself is one adverse effect, and that can be avoided by giving antibiotic prophylaxis or vaccines whenever possible. So this education patients require. So how will be the quality of life? Like how the prognosis has improved, even the quality of life has improved for most of these patients. That again depends on the severity of disease and how appropriately they take treatment. If everything goes well, then the quality is near perfect. They can have they can complete their education, have the good personal life, everything. But the biggest hindrance is the diagnostic delay and also quackery. Quackery not just by the alternate medicine or something, even the allopathic medicine, if not adequately given at the right time, considered as quackery itself. And his neighbors, other people, everybody keeps suggesting these patients about one or the other treatment method, and thus causes a lot of delay in right treatment. So that was about a brief introduction to autoimmunity and the related diseases. This may not be a common question in your exam paper, but remember that you should not miss an autoimmune disease patient. What are the tips by which you can detect those are, there may or may not be infection going on, but there will be some evidence of a long-standing disease process. Like there is going to be unanswered questions in your if you're thinking only of infection, then there may be some unanswered questions among the lab tests, or the patient may be suffering for much longer than what diagnosis you can attribute to otherwise. Okay, so have an open mind to autoimmune diseases. These tests are quite costly, so you should be aware of the diseases to some extent so that you are not over diagnosing or over investigating